Hi, this is Tim from ChiroUp, and today I wanted to talk a little bit about the disc. I wanted to describe Kirkcaldy-Willis's degenerative cascade. He talks about the disc, how repetitive microtrauma can create small circumferential tears in the annular fibers. And over time, those tears can weaken the disc so that now when it's compressed, we see bulging of the disc. If those tears coalesce and form a channel, now this nuclear material inside can bulge and actually herniate to the outside. Over time, whether there's a herniation or not, these annular fibers that attach to the end plate on top and on bottom tend to break down, and we get separation of the disc from the annulus, which compromises the disc's imbibition. The disc doesn't have an arterial blood supply. It depends on getting nourishment from the vertebra above and below through those end plates. So over time, as that nutrition is diminished, the disc thins, which decreases its ability to absorb shock and increases loading on the facet joints and leads to degeneration and instability. Now we know that a lot of people get disc lesions. In fact, asymptomatic disc lesions are present in 30% of the population at age 20, and that increases to 84% by the time that you're 80. Overall, about a third of Americans are going to experience a symptomatic lumbar disc lesion at some point in their lifetime. And one of the ways that we can know how that happens is the rate at which the disc degenerates versus the rate at which the nucleus dehydrates. If the nucleus dehydrates faster than the annulus degenerates, there's not enough pressure to push that disc material outward to herniate. But if the tears in the annulus coalesce before the nuclear material has had a chance to dehydrate, now that's going to herniate. Almost all herniations happen in the back portion of the disc. You can see that the disc is much thinner and much narrower in the posterior aspect near the spinal cords and the nerve root. Most herniations occur in this region, and they occur in the 5 to 7 o'clock region because there's a big ligament, the posterior longitudinal ligament, which goes down the back of the vertebral bodies and the discs, but it tapers at the lower level. So most disc herniations happen at one of the two lower levels, L4-5 or L5-S1. Let's take a quick look at this jelly. I was amazed. This is a pig vertebra, and we just dissected it this morning. And the jelly inside is very much like epoxy, that we can actually deform it, we can move it around, we can scrape it to one side. I've always thought that it was more like crab meat or a little bit more solid, but you can see that this is actually very jelly-like. And that jelly then will balance back out. It's largely water. It's almost solid water. And so that forms a great pillar of support for the vertebral body, that this water is non-compressible. Because of the disc, it can deform, but it doesn't wear out. It does go away, and when it goes away, that's when we have problems. That's the disc herniations that are going to occur in these regions. They can happen centrally, they can happen paracentrally, they can happen in the foramina or the lateral recess. And we know that based upon the amount of herniation, that's going to determine the symptoms. That if a disc herniates and causes a large extrusion or sequestration, this nuclear material has never seen the vascular supply of the body, so it's foreign to the immune system. And when it escapes, it produces an immune reaction, which there's going to be a lot of chemicals coming into the area that are irritants to the nearby nerve root. The larger the amount of material that comes out, the larger the inflammatory reaction, but also the quicker that disc is likely to self-resolve, because those inflammatory products are going to basically eat that disc material away and get rid of it as the foreign material it thought it was. So Chu told us in 2015 that those large herniations are going to respond much more quickly. Regardless of the size of the herniation, when this nuclear material comes outside, there's going to be a chemical irritation. It's going to spill onto the nerve root, and that's going to cause a chemical radiculopathy of radiating pain. Whether or not there's mechanical compression determines how aggressive we have to be with the management and the assessment. That if this nuclear material comes out and actually puts pressure on the spinal cord or on the nerve roots that escape, now we're going to have a compressive radiculopathy. So in addition to pain, this patient is going to have a loss of reflex or a loss of strength. Those are the patients that need MRIs, they need neurosurgical consults. The ones with pain we can often manage otherwise. I hope that this has been helpful. I hope you've enjoyed the model of the disc, including how viscous the annular material is. And I invite you to visit ChiroUp for more information.